Hello, and welcome to this case study on anterior ankle impingement, utilizing arthrokinematics to evaluate ankle dysfunction. The objective of this video is to observe how ankle arthrokinematics can be utilized to identify potential causes of pain and dysfunctional movement sequencing. Today we'll be highlighting reported arthrokinematics of the foot and ankle complex as reported by Loudon and Bell. I'd like to take a moment here and thank Hannah for helping us out in this video. Hannah is a student in our athletic training program at Concordia University, Wisconsin, and she's also a member of the Women's National Taekwondo team.
Hello everyone, Dr. Daryn Smith here. I'm here with one of my students, Hannah, and we're going to be taking a quick look at Hannah's ankle, and we're going to apply some basic biomechanics and see how they can be utilized for both an assessment and a treatment tool. So everything that we're going to do is going to be from the lower leg down. It's not going to be all encompassing for every type of biomechanic that's taking place, but it'll give you a good idea on how to utilize these tools and movements when you begin to learn them and you want to incorporate them into your practice. So what I'm going to ask Hannah to begin with here is, Hannah, can you please move forward into dorsiflexion and stop when you get pain?
About right there.
So about right there, hold it there for us. Where do you have the pain?
Right in the front.
Right in the front of the foot. Now, typically what we would say, let's have you come out of that. Typically what we would say is that when we're tight in the front and you get that closing angle pinch, that it's usually a posterior capsule tightness. But with the foot, we have a lot of moving components here. So we want to go through and check all these different components out. You'll notice that we're on a very soft table, so Hannah's foot kind of sinks into it a little bit. She does have a structural pes planus going on, so she is a little flat-footed, okay? So what we're gonna do is we're gonna start with the lower leg here, and we are gonna replicate the biomechanical movements that take place when she goes into this position and holds it. And we want to see if it increases the pain or reduces the pain. Okay, so what we're looking at here is if I take and I replicate a movement that should be happening and Hannah's pain disappears or decreases, that means that we have some hypomobility there, and or she's just not moving through that particular range at that particular moment with the sequencing that her body currently finds to be the most efficient. It's just not moving enough at the right time. So we're going to figure out if she's got not enough movement or too much movement. If I take and I do the opposite, or I slow down what should actually be taking place, and that reduces the pain, that means we have too much movement going on that her body can't handle. So let's get into this here. We're going to start with the lower leg. And we know that when an individual comes forward into this position and the whole foot needs to collapse, we're looking at the movement of pronation here. We know that that tib and fib should internally rotate. From this starting position, she has a particular degree of rotation that we can't necessarily see. So what I will do here is, prior to her moving into this position, if we know that this internally rotates, I'm going to take and I'm going to ask her to keep her knees straight towards me. I'm going to take my hands and I'm going to internally rotate those two bones, okay? And then she's going to come forward. So go ahead and come forward and stop if you get pain.
Right there.
She gets it right there, okay? So the internal rotation that should be taking place, come on out, okay? if we didn't have enough of that, and that was the cause of the problem that was giving her the pinch or the pain, that would either reduce things and or get rid of them, but it didn't. Okay, let's go in the opposite direction. We know that it should internally rotate. If she's got too much internal rotation, and that's what's causing the pain here, let's slow it down and decrease it a little bit. So what I'm going to do is I'm going to take, and I'm just going to slightly externally rotate her, not a lot, because I still want her to be able to come forward. So I want to know when she comes forward if this makes things better or worse. So go ahead and come forward. Stop if you get pain.
No, right there.
Right there. So would you say that's worse?
Yeah.
Definitely worse. Okay, so we know that if we add in external rotation, it makes things worse there. So again, we're not finding anything that's clearing stuff up here. So we went in both directions. If she was hypomobile, internal rotation would have helped. If she was hypermobile and there was too much movement taking place too quickly, the external rotation would have aided us. Okay, now we're going to move down a little bit. So I'm going to go to the tib and fib. And what I'm going to do, and you could do this with a belt, take it around the backside and put it behind your waist and pull forward. When she comes into this position, the tib and fib should actually slide over the head of the talus and dive forward, down, and in. Okay, so what I'm going to do is I'm going to take and put my hands on the tib and fib, and I'm going to start by pushing them forward before she comes forward. Go ahead, Hannah, come forward for us. Stop if you get pain.
Right there.
Right there. Still getting pain. So this extra glide that I'm giving her, not enough. Come on out. Okay. If I take and I push her back in the opposite direction, go ahead and come forward. Stop if you get pain.
Right there.
Ooh. Okay. So again, that's kicking in real quick. So again, she doesn't seem to be hypo or hypermobile with either one of those particular movements. Now we're going to go down to the next bone. We're going to look at that talus. We know that that talus, if the tib and fib glide forward, we know that that talus has got to glide back. Okay, so they both happen together to keep the joint centered and stable. In addition, that talus also dives down and in. So it's going to come towards the midline and it's going to medially rotate. And the front edge of that talus is going to tilt downward, or it's commonly referred to as plantar flexion. Okay, so what I'm going to do is I'm going to put my hand over that talus. Okay, I can only get over the head and neck with this, and I'm going to be a little bit over the mid-tarsal joints as well too. They're also tightly packed that it's hard to just say you're only getting one, especially in a functional position when you're weight bearing. So I'm going to take Hannah, I'm going to get right in the joint space. Okay, so I am below the joint space rather. I'm going to have the webbing of my fingers. My thumb is going to go right over by the sinus tarsi, and then I'm going to come across the head and neck of that talus. I'm going to take and I'm going to push my hand down and back on an angle like this, since that's how everything would kind of fall and rotate in. So I'm going to set it, and then I'll rotate. Go ahead, come forward. Stop if you get pain.
Right there.
Right there, okay? So come on out of it. That's what should take place, but she still gets pain, okay? So the fact that I gave her more and she still got the pain means we're still not figuring out what's causing that pinch or pain biomechanically. Let's take, and what I'm going to do now is I'm going to take the talus, I'll push it back, but I'm going to twist it this way and rotate it this way. Come on forward, stop if you get pain.
Okay. This is just as far as I can go.
Okay, that's as far as she can go. Come on out of it. Okay, so as I stated before, when you get your hands on this area, you're really looking at the mid-tarsal joints, the talonavicular joint, the calcaneal cuboid joint, as well as that talus. So what's happening here with Hannah is that when she comes forward, so come forward, stop when you get pain. Okay, she's got that pronated foot. So come on out of it. that pronated foot, being in that pronated position, is home for her. Her body considers it neutral since this is flat structurally. Okay, so in order for her to turn things on from a proprioceptive standpoint, flatten out the foot, splay the metatarsals, and really get the pressure sensing going on the bottom of that foot tripod, she has got to take and pronate more. So she's got a lot of pronation to get in and out of that position. As soon as we take and we slow that talus down and we slow the talonavicular and calcaneocuboid joints down from diving down and in too much and rotating further into that pronation, the pinch goes away. So let's just look at it real quick one more time with my hands on there, pre-positioning versus my hands off. So come forward till you get the pain.
Right there.
There it is right there. Come on out. Okay, I take my hand, I'm pushing straight back. So it's back, and then I twist laterally because I know to get more pronation, you'd have to twist medially. So I'm doing the opposite, or I'm slowing down the timing of how quickly everything is dropping down and in, allowing the bones to clear in the pinch to no longer be there. So again, I'll press back before she moves. I rotate, and you can even see when I do that, her arch comes up a little bit. Okay, come on forward, stop if you get pain. Right there, any pain?
No pain. That's
Try to make it hurt. Come forward. Move through it. Nothing?
No, just tight calves.
Okay, come on out of it. Okay, so you can see how we can take the movements that we're familiar with and we've learned in kinesiology, all these arthrokinematics that are taking place, and we can facilitate them and cause them to happen more. Okay, if we facilitate a movement that should be there and it relieves pain, then we know we are a little bit hypomobile. We're missing some of that movement. If we hinder that movement or slow it down and it releases the pain, then we know that we're moving too much. We could be hypermobile, and or we may have some neuromuscular re-education we got to work on to stabilize a little bit more. Thanks for joining us. Appreciate your time.
So what's our take home here? What's our clinical gem that we can utilize for practice? Well, the evidence-based truth that this video was designed to illustrate involved recreating arthrokinematics and their associated physiological movements. We can utilize these things in order to aid in identifying and treating root causes of potential dysfunction. So what type of strategy can we use to apply this new evidence-based truth to the body? Again, as in previous videos, instead of only asking what it is and simply labeling the injury, ask yourself why it is. What is the root cause? Additionally, how will you use these osteoarthrokinematic movements that we discussed today? Will you incorporate them into additional foot, ankle, and lower leg assessment, treatment and reevaluation of therex so that you can make progressions? What about other lower extremity injuries, not only at the foot and ankle complex, but further up the chain, such as the knee, hip, pelvis, and low back? Here at the channel, we're dedicated to establish and foster a positive interprofessional environment in which learning can occur regardless of your profession and/or previous training. Please help us spread the word to your healthcare movement colleagues looking to incorporate more evidence-based research application into their own practice. As always, if you liked what you see, please subscribe and join our YouTube channel community, where the #1 goal is improving the lives of those we serve.